So I'll be speaking today about clinical trials and future treatments. The objectives will be to review the rationale and importance of clinical trials in gynecologic cancer, to review the history of clinical trials in ovarian cancer, to describe the different types of clinical trials, and to discuss currently enrolling clinical trials, and finally to look at future areas of interest and investigation. So what is a clinical trial? A clinical trial is any investigation of a new drug, a combination of drugs, clinical intervention, or treatment. And this can be new unapproved drugs. It can be FDA-approved drugs utilized in new situations, or even new combinations of drugs. All clinical trials involving human subjects are required to have Institutional Review Board, IRB approval. Clinical trials, and this holds true for both retrospective trials as well as prospective trials. And retrospective trials are really going back and looking at what the intervention did once the intervention has already been given, and a prospective trial is to do that as the intervention is being given. So why do we do clinical trials? We do it to improve patient care, to be able to provide state-of-the-art care to our patients. And despite a new trial, a trial being new, it's really at a tail end of a very long investigative process. So for example, Taxol, which was discovered from the yew tree in 1967, didn't make it to clinical trials till the late 80s. And it didn't become standard of care till the mid-90s. And as Dr. Hoskins pointed out, to this date, it remains as part of the standard of care in the treatment of ovarian cancer. But you can see how long this process is. So why do we participate in a clinical trial? What's the benefit? Well, there's the benefit to society. Clinical trials have really gotten us to where we are now. And as Dr. Hoskins shown, we've really made improvements in survival in ovarian cancer. And only about 3% of patients with cancer actually participate in clinical trials, and yet it's such an important part of making progress in this disease. In addition, there are benefits to the individual. Trials are usually done with significant oversight. Really, in terms of toxicity, every patient is monitored so closely. In addition, it allows you to get new promising drugs 10 to 12 years prior to FDA approval, if they ever get FDA approval. And many drugs are paid for in clinical trials. And most phase 3 trials are positive. So you already saw this slide, but it's always good to review, and it always makes us feel good when we see that, that we have actually made progress, from the 1970s when our median survival was 12 months, and today with IP chemotherapies as high as 66 months. So what are the advantages of a clinical study? So as I mentioned earlier, it gives you access to new drugs and interventions, which you may not have otherwise access to. You have very close and stringent monitoring during the trial. It allows you to take an active role in your health care, since you decide whether you're going to participate in this trial. And you could be among the first to benefit from these therapies. And as I said, most phase 3 trials are positive. So what are the disadvantages? So the logistics of a clinical trial can be extremely burdensome. There is very little flexibility. For those of you who've been on clinical trial, you know that you have to stay on schedule. You have to keep those weekly appointments for your blood tests, for your treatments. So that's definitely one of the downsides. In addition, there are unknown side effects. These are new drugs, so part of investigating them is to find out how they adversely affect patients. In addition, the new approach, while we are all very excited about new approaches, and there is always excellent preclinical rationale to doing these studies, they may not work. And as I said, very few patients do participate in cancer clinical trials. So how do you decide whether to participate in a clinical trial? So you want to really think about, how serious is your disease? What is the outcome with standard therapy? What are your other options? What is the standard of care? The toxicities associated? What are the goals of the study that are being proposed? Is it just to decrease toxicity? Is it to improve efficacy? Do those endpoints seem reasonable to you? What is being investigated? Is it a new agent, or is it a new way of already using an approved drug? What are the risks? What are the costs to you? What are the added logistics? And can you manage the added logistics? And then what's in it for you? Is there a chance that you're going to do better? And what's in it for future generations? Even if it may not help you, could it help the others with ovarian cancer? So who pays for these clinical trials? So private foundations, the government through their grant mechanisms, either individual grants like the R01 mechanism or cooperative groups, the GOG, which is the Gynecologic Oncology Group, NSABP, RTOG. There are SPORE grants that also help support clinical trials. And then industry also pays for clinical trials so they can get new drug approvals and then also get new indications for their drugs. What are the types of clinical trials? So there are preclinical trials, and these are trials that don't involve human subjects, and these are trials that are done in the laboratory. They're usually done on cell lines, on xenografts, or animals. And usually we have this data which really helps take these drugs into the other phases. The phase 1 study is usually, the endpoint is toxicity, and to determine a dose that we can then take into the phase 2. The pros of that are usually these trials are open to many patients, so the entry criteria are not stringent, and the cons are that there's limited data and toxicity information, because that's what we're trying to find out in this type of clinical trial. In a phase 2 trial, the endpoint is really getting an idea of, is this drug active? So it's really to get some idea of efficacy, and then this really gives patients the ability to get access to new drugs and treatments before they're approved. And the cons to that is usually the criteria are a little more strict in terms of where you need to be in your treatment to get into these studies. And then phase 3 studies are really the gold standard to determine if one treatment is better than the other. And it's usually done to compare a treatment that is the standard of care. And so the pros of that is that you may get better treatment, and the con is that you may get on the experimental arm and not get the drug being studied, or the toxicity may be higher, or it may not be as efficacious. So as I said, the phase 3 study is really to determine, is it better? Is it better than what the standard is? It compares 2 treatments side by side to see which is better. It looks usually at response rates, progression-free survival, and overall survival. When we look at these trials, these are done in a very stringent fashion, where we utilize different methods like randomization. So randomization is just a method of assigning patients to treatment groups, and we really need to be careful about avoiding bias on the part of the investigator or the patient. So you don't always get to pick what arm you're going to go on. This gets randomly assigned, and the goal of that is really to create groups that are similar, so when you actually look at the data, you can say one really is better than the other. And then they're often blinded, so a single blind study is where the participants don't know which treatment they're receiving. And a double blind study is where the participants and the investigators don't know which treatment the patient is receiving. So as I alluded to earlier, traditional drug development takes a long time. It can be up to 10 years before a drug can get full FDA approval. And usually it's in phase 1 for about 6 to 12 months. It then goes on to phase 2 for another 6 to 12 months. It's in a randomized phase 2 setting for about 2 to 3 years. And finally it goes to a phase 3. Sometimes it can bypass the randomized phase 2. And that's usually there for about 3 to 5 years before you can actually before it can actually be approved for common use or full FDA approval. So with newer targeted drugs, there seems to be a push for newer drug development strategies, and really to try to take targeted agents in the phase 1, 2 that may be more, specific to certain types of cancers or certain mutations that patients may have, and really, cut that phase down to 6 to 24 months and try to move those into limited phase 3s, lasting 1 to 3 years to try to obtain FDA approval sooner so patients can have access to these drugs sooner. So shifting to the Gynecologic Oncology Group, it was organized in 1970 by gynecologic surgeons who had a special interest in quality clinical research. And now it has become one of NCI's funded cooperative cancer research groups and has actually merged into the NRG group, which I'll talk about later, and really is responsible for the conduct of the vast majority of clinical trials in the United States. Over greater than 300 trials have been done through this group. So just looking at the history of clinical trials in ovarian cancer, so GOG, again, these are all Gynecologic Oncology Group trials. GOG 25 looked at melphalan in the treatment of ovarian cancer. GOG 52 established cisplatin and Cytoxan in the treatment of ovarian cancer. GOG 111 introduced paclitaxel to that treatment, and with GOG 132 and 158, carboplatin and paclitaxel became the standard. And then with GOG 218, as Dr. Hoskins alluded to, the addition of bevacizumab was studied, and with GOG 172, IP therapy with cisplatin and paclitaxel was looked at, and finally GOG 262, which will look at carboplatin with a weekly dose-dense schedule of paclitaxel plus or minus bevacizumab, and that trial is completed, but awaiting analysis. So what are some areas of interest for future treatments? So I'm going to talk about several areas: PARP inhibition, angiogenesis, immunotherapy, and survivorship. So PARP inhibition leads to tumor specific lethality to BRCA deficiency. So really tumors that have homologous recombination deficits, such as patients with BRCA1 or 2, may have an improved sensitivity to PARP inhibitors. But clearly, these are not the only patients, and really, there's a whole gamut of patients who have BRCA who may respond to these treatments. So in terms of the PARP inhibitors that have been studied, olaparib has been studied the most, and I'm going to go into a little bit of detail, as well as veliparib is the compound that the GOG is studying. Rucaparib and niraparib are two PARP inhibitors that pharmaceutical companies are now moving into the phase 2 and 3 arena, so some of you may participate in these studies. And then BMN 673 is another PARP inhibitor that appears to have promising clinical activity. So the phase 1 trial with olaparib found that 400 milligrams twice daily was the appropriate dose, and they saw 28% response in BRCA patients, in patients with BRCA mutation carriers that had ovarian cancer. And you can see here, the marked response, tumor response. Here you have a complete response, and here you have a partial response. And this is just with an oral agent that is not a cytotoxic chemotherapy. So obviously this was very exciting. So they did a phase 2 trial in the maintenance setting that showed improvement in progression-free survival. And now they, given that data, they're planning a randomized phase 3 trial in BRCA mutation carriers through the GOG partners mechanism. So veliparib, another PARP inhibitor, as I said, this is the PARP inhibitor that is being studied through the GOG. GOG 280 was recently completed, and the results were reported at SGO. It was a phase 2 trial that looked at activity in BRCA carriers, and they did note activity. And so there are several other phase 1 studies that the GOG is undertaking presently, really in preparation for their phase 3 trial with carboplatin and Taxol in patients with the initial diagnosis of ovarian cancer. So moving on to angiogenesis. The idea behind angiogenesis is that, tumors need they need nutrients, they need oxygen, and really if we can cut off their blood supply, they won't get these and will die. So there are several different drugs that have been looked at in terms of inhibiting angiogenesis. So AMG 386 inhibits angiopoietin 1 and 2. Bevacizumab, which is a monoclonal antibody, inhibits VEGF. Phosphatidylin is a microtubule destabilizing agent that actually works in the endothelial cells to inhibit proliferation of these cells and thereby cause cell death. And then sidarinib is another tyrosine kinase inhibitor, and pazopanib is another multi-kinase tyrosine kinase inhibitor. So in terms of first-line treatment clinical trials with bevacizumab, we talked about GOG 218 was the phase 3 trial that showed an improvement in progression-free survival of 3.8 months in the frontline setting for patients with ovarian cancer. GOG 252 is the phase 3 trial of bevacizumab IV or IP chemotherapy in frontline patients, and this study has been completed, and many of you have probably participated, and we are now awaiting the data. GOG 3001 is a phase 3 study of AMG 386 with paclitaxel and carboplatin as the first-line treatment of patients with advanced ovarian cancer, and this is the current upfront ovarian cancer clinical trial that's available through GOG partners. In terms of recurrent ovarian cancer, there are several randomized phase 2 trials that involve bevacizumab. There's a randomized phase 2 of single-agent Bev versus bevacizumab in combination with phosphatidylin, two different inhibitors of two different pathways in the angiogenesis mechanism. And then GOG 186, which is looking at oral everolimus and bevacizumab versus placebo and bevacizumab, is can we improve bevacizumab's efficacy by adding other agents? Moving on to ovarian cancer immunotherapy, the idea behind immunotherapy is to utilize the body's immune cells to try to attack the cancer cells. GOG 255 is a randomized phase 2 vaccine study in the second or third line remission. EGEN 001 with liposomal doxorubicin is a trial in patients with platinum-resistant cancer, and the EGEN 001 is an interesting drug, which is it's an IL-12 gene with a polymer delivery system. And what IL-12 is a potent cytokine that enhances the body's immune system to fight against cancer. GOG 3003 is VTX2237 with PLD. And this is a toll-like receptor 8 agonist. And again, this also activates multiple areas within the immune system. And then agovabamab is a CA125 targeted immunotherapy agent that's actually in a phase 3 international trial for maintenance. So we'll have to await some of these results. So with the advent of immunotherapy in in cancer clinical trials, we've noted that we've had to kind of modify the way we evaluate patients on these trials. And the traditional RECIST criteria based on your CT scans may not be accurate. And here, this is just one example. You can see the lesions here on screening, and then at week 12, you see actually increased inflammation and a new lesion that's present. And with the standard RECIST criteria, you would actually have come off of clinical trial. But here, if you see at week 16, you see that the lesions are responding. And then week 72, there's a durable and ongoing response. So with this, we've learned, and we've had to modify our RECIST to RECIST immune criteria, which we use to follow patients on immunotherapy trials. So in addition, survivorship and lifestyle factors are exceedingly important, and GOG 225 is the first ovarian cancer survivorship trial. And it's really looking at, will changes in diet and physical activity affect how long a patient will stay in remission? So what is the take-home message? So basic science leads to discoveries in the laboratory that can be translated into clinical medicine. These help us identify, important therapeutics, which can then be studied to help our battle against cancer. And clearly, screening and prevention is even better than curing cancer. It's better to prevent. So what are some of the new directions? Pre-treatment patient selection for trial is important. So we can now look at specific histologies where patients with certain histologies may respond to certain therapeutic strategies better. Pathway activations, looking at genomics. The TCGA database has now classified tumors into very distinct tumor types, which may respond differently to different therapeutic agents. And finally, identifying early biomarkers for success or failure. Clearly we've identified that BRCA mutation carriers, that is a biomarker for PARP inhibitor use. So we need to do more of that. Can we do this in tumor tissue? Can we do it in blood, which would be even better? Can we do it in saliva? And we need new trial designs to not wait 5 to 10 years so we can rapidly acquire new drugs in the armamentarium that we have. And how can we try to control induced toxicity? So just a few facts about drug development and clinical trials. New medicines are responsible for 40% of life gain expectancy in the last 25 years. It takes 10 years for a new drug, and it costs $500 to $800 million. And only 1 in 50 drugs ever make it. Less than 1/3 of drugs that begin clinical testing are evaluated in phase 3 trials. And less than 5% of cancer patients participate in clinical trials. And the number of active investigators in the United States has actually declined since 2001. So this stimulated the Institute of Medicine to reorganize the clinical trial enterprise. And several of their goals was to include incentivizing participation of patients and physicians. They reorganized the 10 cooperative groups into 4 adult and 1 pediatric cooperative group. So this is the and part of that was GOG joining NSABP and RTOG, and really restructuring to prioritize phase 1 and 2 trials leading into phase 3 trials. So why are clinical trials critically important to the future of gynecologic cancer? The best treatment is often poorly understood. It gives patients access to novel, cutting-edge treatments. Advancing cancer is a dual effort from both researchers and patients. It gives patients empowerment and involvement in their care. Patients get more structured care, as I said. And without clinical trials, the goal of improving patient results and quality of life is impossible. So what can you do to help? You can help raise awareness. You can join advocacy groups. You can be politically active. You can encourage Congress to fix drug shortages. You can lobby for increased research funding for ovarian cancer. You can support foundations like the Women's Cancer Foundation for cancer research, and you can participate in clinical trials. And for all of you all of you who have participated in clinical trials a big thank you.